All right, why don't we get started? Thanks again for those of you who have joined. I'm sure a few more will pop on. But this is our next webinar focused on lymphatic therapy from the Boston Lymphatic Center. And it's a great honor to introduce Katrina Jancy. She's one of our go-to therapists, particularly for patients in the perioperative setting. So we thought it would be great for others that often share patients with us out in the community that don't necessarily see the patients or manage their perioperative compression and how we do it here and how we can work with their local therapists. Because often, as I'm sure Katrina will review, there's an important relationship that develops between the local therapist and us to make sure the patients are getting their optimal compression. So I'll leave it to Katrina, and then we can certainly take questions at the end. Feel free to put them in the chat, or we can have you come off mute at the end. Thanks so much, Katrina.
Yeah. So hi guys, my name's Katrina. Actually, can everyone hear me okay? I have a little mic, so. Okay.
Nope, sounds good.
So my name's Katrina. I am one of the therapists here at Beth Israel. So like Brett said, there's a lot of I see a lot of the patients preoperatively for the debulking surgery. So we'll just go over, just some tips and tricks, things that we do preoperatively for their garment measurements for their surgery. Let's go do that. Okay, there we go. So briefly, this is just our team at the Boston Lymphatic Center. So at the top is the surgery team, so the surgeon and his nurse and nurse practitioner. To the right is our nuclear medicine MD, who does the lymphocytographies. And then on the bottom right is lymphatic medicine, Dr. Brett Carroll and Betsy Rose. Those are kind of the first faces. If a patient of yours is coming to the Boston Lymphatic Center, they typically will see Dr. Carroll or Betsy Rose first, and then they'll get referred over to one of our therapists. On the left-hand side is our body imaging, so our radiologist who reads the MRIs. And then last but not least, on the bottom left-hand corner is our therapy team. The therapist all the way to the right is our inpatient team lead. And then the three on the left are our outpatient therapists. So it's me, Kathy Shalou, and Tegan Guilfoyle. So brief outline of what we're going to go over today. So first, we're just going to quickly overview the debulking surgery, kind of what that entails, then how to measure for the compression preoperatively, then just any post-operative encounters, things that we have come across, and then just other considerations, things to think about for the surgery. So this is just a brief slide on the surgical debulking. So basically, this surgery is offered for patients for when they're maximized management of the fluid component of the lymphedema with all the conservative measures. So this remaining fat hypertrophy can cause discomfort, poor function, and impaired quality of life. So these are the patients that you typically see for CDT, or they're in custom garments and they still have a size difference in their arm or their leg. That's kind of that remaining fat hypertrophy that sits kind of in the limb. So surgically, a curette is inserted through dozens of small holes to liposuction out the extra subcutaneous adipose tissue. So basically, they use the unaffected limb as a guide for desired volume reduction, which we'll go into a little bit later. So how do we ensure that the fat hypertrophy does not return in the affected arm or leg? And that's to wear a lot of compression. So I'm sure some of you have heard of this before, so we'll just kind of go over exactly what that entails. So as you can see here are just some photos of what the patients wear post-operatively. So the two photos on the left-hand side are obviously what patients would wear for their leg. So all of our garments are custom flat knit Jobst Elrex compression garments. This protocol that we're using actually is developed by Dr. Hakan Borson in Sweden. So, and he always uses this type of protocol. So that's what we follow actually. So on the left-hand side, you'll see you got a waist high, 1.5 leg compression garment. So in the thigh portion, it's a class 3, and then in the waist and the short portion is a class 2. That compression is worn 24/7, besides, I guess, 23/7, so people can shower, but basically all the time, day and night. And then in the middle is a thigh-high compression garment, and that is a class 2. That is just layered during the day. So patients wear 2 layers of custom flat knit during the day, and then just the one waist-high layer at nighttime. On the right-hand side, you'll see for upper extremity. So it's again custom Alvarex compression sleeve class 2. And then there's obviously a glove right next to it that patients wear. And then next to that is a ferro wrap, so just an extra compression on the hand. And then next to that is an easy slide, which we'll go over a little bit later. But so these are basically what the patients have to wear 24/7 for the rest of their life. A lot of patients are wanting to get, an extra surgery to hopefully at some point decrease their time in compression. However, if a patient really just comes to get this debulking surgery and that's it, that is what they wear for the rest of their life. The 2 layers, especially in the lower extremity. And, again, if a patient decides to get a secondary procedure like a lymph node transplant or a lymphovenous bypass, we could maybe consider weaning off of some of this type of compression. But it's not something that we ever promise our patients. It's obviously a goal, something we would like to see, but I don't want to set that false expectation going into it. And a lot of the times our patients are not wearing this type of protocol. They could be wearing some sort of flat knit compression, but they may not be wearing, this amount. So a lot of the times it's patients have to almost up the ante a bit before they could ever kind of decrease again. So these are just the forms, just for reference. I might come back to these just to kind of give reference on types of measurements and where to take them. So obviously on the left is the lower extremity measurement form, and on the right is the upper extremity. Okay, so now kind of getting into the nitty-gritty of actually taking the garment measurements. So as I mentioned on an earlier slide, our goal is to use the unaffected limb for volume reduction. So a lot of these measurements are actually taken on the unaffected leg or arm. So in this case, we're talking about the leg. So in the unaffected leg. So the first couple measurements, though, we do actually take on the affected leg, and that's just because the actual surgery itself is done on, from the lowest part of the leg up to the thigh, but he does not go into the foot or even like the lowest part of the ankle. So for the only two measurements that are taken on the actual affected leg are the A and the Y. So just as for reference, I don't know if you can see my mouse, but the A measurement and the base of the toes, and then the Y measurement that goes around the ankle. We wouldn't want to take those on the unaffected side, only because if they have foot swelling, then that will just make it incredibly hard to wear the compression on their feet, and especially double layers of it. So we measured those on the affected leg. And for that Y measurement, we actually make sure the patients are fully dorsiflexed and add 2 centimeters to that measurement, just because that the anterior tibialis tendon can definitely be affected, especially when they dorsiflex. So we make sure that we give a lot of extra room there. And then the remainder of the measurements are all taken on the unaffected leg. So again, just for reference here, so basically from this B measurement all the way up to G, the top of the thigh, is taken on their unaffected leg, because the goal is that after surgery, their legs will be symmetrical and that they will be able to fit into the garments that were measured for the opposite leg. For those measurements, we also do max tension on that tape measure. And then we also reduce it sometimes even by 1 to 2 centimeters on that F and G measurement, the ones at the top of the thigh, because sometimes more gets taken out of there. A couple other things that we typically are changing in this first set of garments is first, sometimes we won't put silicone in the first layer of the waist high, and that's just because sometimes we just don't want the silicone to be touching maybe one of those tiny port sites. And we don't want to cause a tourniquet at all. So in that first waist high layer, we don't put silicone. And then we'll also just recently, we're kind of changing this all the time, but we're thinking about trying to put a silk pocket into the Y measurement for that anterior tib tendon, just to kind of give it a little bit of extra cushion if patients need it. Um, and so with this, the patients are measured for these preoperatively around 6 to 8 weeks prior to the surgery. And so they need two sets of these compression garments delivered to the hospital or here in their hands prior to surgery. If they don't have the compression, then they are not getting surgery. So we're really strict about making sure that they have everything that they need and everything is, exactly how we ordered. Um, and 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 yes, so but this also means though that the patients really need four compression garments. They need two waist high and two thigh high. So it is a lot of garments that the patients need to get in order to have the surgery. And then the last thing that we have patients order is a Magnide. So this is what it looks like. It's basically, I'm not sure if any of you have heard of an Easy Slide, but it's similarly, it's for basically a closed toe compression garment. So basically the patients will put their foot in this area, and then they slide on their compression and then they take it out. They probably put the compression garment up to like their mid calf and then they pull it out by this handle here, and the magnets that are attached here basically all separate and they can pull it out. This is not only really helpful for patients to use after the surgery, it's also used by the surgeon who will use it in the OR, because basically when the patient wakes up from their surgery, they'll have that first waist-high layer on their leg. So he uses it in the OR too to help get it on for patients. So he uses it, and then it's also really helpful for patients to use after surgery, really just to kind of reduce the friction of putting the compression garments on. And especially if there's pain involved, which there typically is, this helps kind of reduce the pain as well, just because, it's not like a really tight garment on a pretty sensitive leg. Um, so for the upper extremity, um, similar yet different in terms of the measurements. So again, most are taken on the unaffected side besides the CC measurement, which is the wrist measurement. So just for reference here, this measurement here is taken on the unaffected arm. And that's really because, again, he doesn't go into the hand for surgery. So we want to just make sure that that measurement is super loose because we don't want to get any extra hand swelling after the surgery. So we just keep that measurement nice and loose, and we also sometimes even add a centimeter onto that just to kind of have it as loose as possible. But then the rest of the measurements are taken all on the unaffected arm, again, similarly to have the same type of volume reduction. Um, with that, the other thing is, again, as I mentioned in the lower extremity, we don't have silicone in the upper extremity garments either. So a lot of patients put silicone at the top to kind of help keep it up. But again, for the same reason, we don't do silicone. So we add a cap and a strap, which I think you may have seen in that first picture. And basically, this kind of helps keep up the compression garment. So it goes over their shoulder and then around their chest to help keep it up. Some of these, extra modification, really just the silicone and this cap and strap, really it's only for their first set of compression garments. After that, they can go back to doing any amount of silicone possible. A lot of patients want to get rid of the cap and strap. They find it a little annoying. So they typically will after the first, once they're due again for compression, they can get rid of it just for that first one. The other thing to mention is gloves. So gloves, it really kind of depends on the patient and what their hand is like. Do they have hand swelling? Do they don't have any hand swelling? So, sometimes if the patients have like an older glove that, is in pretty good shape still, we'll have them use that type of glove after surgery. Some get measured for custom garments. Others, we just do like a Jobst Bella Strong garment, only because sometimes with custom, we aren't sure what their hand or fingers will be like after surgery. So measuring custom would be difficult if they do have more swelling, they may not be able to tolerate the glove that we ordered for them. So it really just depends on the person. And then the other thing is we'll get a ferro wrap, which was in that photo as well, that you just put on top of the glove to help with just additional compression for the hand swelling that patients may get after surgery. And then again, two sets of everything, two gloves, two sleeves, and just one ferro wrap is what patients again have to either have in hand or ordered and are delivered to the hospital here before surgery. Again, if they don't have them, then they cannot get surgery. And then they have to order an easy slide, which people may have heard of this. I feel like it's a little more common than the Magnide, but basically it's just another type of donning aid to help get the compression sleeve on. So basically they stick their arm in here and then put the sleeve on, and then they pull it out from their compression, like near their hand, to take it out. Again, reduces friction, helps with some of the pain that's associated with the surgery, and patients find it super, super helpful. And even, years after their surgery, they're still using the Easy Slide. So it's a really, really helpful tool. This isn't covered by insurance, so patients do have to pay for it, but I feel like it's the best money they could spend because it really, really helps. So these are just kind of some post-operative encounters or things that we come across after surgery. So first is just some skin irritation in certain areas. I would say for the upper extremity, it's not as common, but sometimes they can get some skin irritation at the axilla or at the antecubital fossa. Definitely not as common, but can happen. Um, so, it's a lot of problem solving, in the hospital and in the clinic. Like some will put, certain padding underneath the armpit if it's like really digging in. Or, they'll put a Mepilex or something on their antecubital fossa if there's like some redness noted there. But again, these aren't as common. The lower extremity is definitely more common only because we have two layers there. Um, so most of the times they happen at any of the bony prominences in the foot, again because there are two layers on the foot, or at the anterior tib tendon is mostly where we see it. We wanted to kind of do a look back, and so stay tuned to see kind of trying to find trends of exactly like which patients are developing some skin irritation and which aren't. We did a quick look back and noticed that a lot of the patients were over the age of 65 and had like more fragile skin. But TBD on that. It was just like a brief look back. But all of them are really handled on a case by case basis. Sometimes, if it's really bothersome to the patients, then we will have them take off one layer. They are really good about reaching out to us and kind of keeping us updated, sending us photos. And this is actually where local therapists are super helpful, especially if someone is coming far away to kind of manage and kind of lay some like professional eyes on some of the skin irritations that we come across. So it's always good to have for patients to have a local therapist to help with that, especially if they can't make it here. But again, so they are handled on a case by case basis. But again, so some will just remove one layer of the compression, so it's less. And then sometimes we'll make, like, if I have like some gray foam that I use like for CDT, I'll like make a little bit of I'll make a donut hole and kind of place it on to kind of relieve pressure off of that area. A lot of these times, eventually with some of these measures, they will heal on their own. Um, and then lastly, sometimes we'll have people actually just stretch out their compression garments. So we'll have them put like either a can or a jar of something like into the foot of it while it's drying to help stretch it out. And sometimes that helps too. So those are just kind of some tips and tricks of things that we recommend for patients to try if they're having some bothersome areas down by the foot. The next thing that some people encounter is just some hand swelling after the surgery. Obviously, this is for the upper extremity. It's from most of the time it's for patients that have already had hand swelling prior to, and they just have an excess amount or more than they had pre-surgery. A lot of the times it does heal on its own, but that's why we do the 2 layers of a glove and of a ferro wrap, because we just want to mitigate that amount of swelling. If that's not enough, and sometimes it isn't, we will have patients wrap their hand, and that, just with a short stretch bandage or two, to try to get the swelling down to as much as they can. And then we measure them for a custom garment to kind of keep it down. But that's probably like the biggest thing that we notice for after surgery in the upper extremity is that just extra hand swelling. People have post-op swelling, so it should go down over time. There are some patients that have some hand swelling that they're still managing, because he doesn't go into the hand. Um, so that's one thing that patients are do notice after the upper extremity. Um, and then lastly, patient reported ill-fitting compression garments. So whenever patients are coming to get measured for their compression garments preoperatively, one of the things I always tell them is that this is a guesstimate. We are taking measurements on the opposite leg or arm. So when people come out of surgery and say that it's not fitting right, obviously we try our best to get the measurements as accurate as possible, but we're not taking measurements on their true arm. Um, so, and sometimes even the surgeon will take out more than, what, and make the arm almost even smaller, like your arm even smaller than the other one. So, it is definitely a guesstimate. And, because of this, we don't really replace the compression garments. So, as you all know, if there's an issue with a custom garment, they're eligible to get it replaced. But for this, sometimes the patients order the garment or they're ordered past that return window. And also, again, patients will say immediately post-op, if it doesn't fit well, that they, should get a new one. And then, we might be replacing them a lot more often than, really is necessary. And with that, a lot of the times people feel that they don't fit as well as because sometimes they just have a hard time like really pulling it up. This is most of the time with the double layers in the leg is that, we find that patients feel like it's kind of falling down, it's loose, but they're just not pulling it up high enough and they're not recruiting fabric from like below, like to in their calf area and bringing it all the way up. So sometimes it's just like extra education that we have to give to patients. Have them use donning gloves because that always helps too. Um, and then the other thing about this too is, like I mentioned earlier, a lot of patients have post-op swelling. So it might even be that they feel like the compression garments don't fit them well now, but then maybe in a couple weeks or even, a month's time when the swelling, that post-op inflammation goes down, that the compression garments fit them better. So it's a lot of that just education right after the surgery. They actually do see not only they see a nurse practitioner or a PA at their week mark, they also see one of the therapists here to kind of give them just this extra education and kind of reinforce, the fit of everything looks okay. And, it's just a lot of, adjusting it throughout the day. And that's just kind of how it goes, at least for this first set, when again, it is just a guesstimate. Um, but yeah, a lot of the times people say initially that they, don't fit, but then again, as time goes on, they do start to fit better. And then really, I mean, depending on insurance barriers and all of that, patients could get, compression garments as soon as their 3-month mark, depending on like when exactly they were ordered. Sometimes patients would rather pay out of pocket to get new ones, and that's up to their discretion. But a lot of times we're just waiting for their insurance to be ready to get new compression garments. So leading into my next point here, insurance. So I know this is probably in the back of everybody's mind because there's a lot of compression, especially in lower extremity, that patients need to get. So a lot of the times we'll try to time it with their insurance and when they're due again for compression. But that's not always perfect. That would be in an ideal world, but unfortunately, it doesn't always happen. So a lot of the times, patients might have to pay for them out of pocket, or maybe they insurance only covers three and they need four, so they have to pay for that fourth one. And so this is always something that I talk with my patients, a while in advance and say, like this is hopefully we can get with insurance, but you may be responsible for it. And I like to set that precedent up ahead of time just so they have an idea financially what they're signing up for. Um, but but yeah, will always discuss this before moving forward with anything, just so they know. And then briefly, I'll just quickly go over just the bilateral involvement, especially for, well, mostly for lower extremities. If a patient has involvement in both legs, then, we can't really use the opposite leg as a metric to say, okay, like let's, base off of this leg because they also have lymphedema in that leg. We actually work closely with the radiologist, and they actually will tell us how much circumferential fat is in the leg. And we basically do an estimate of, how much of that we can remove for a circumferential measurement of their compression. So as I mentioned earlier, most of this is a guesstimate. This is also a guesstimate, even more so because we're not even, we're kind of just trying to estimate how much fat is going to be taken out from the MRI. And then lastly, just some post-operative garment measurement things that we kind of go over. So basically patients are seen, like I said, at their first week mark to kind of go over just making sure their skin looks okay, and then a therapist will help them with garmenting. And then they're seen at their 4 to 6 week mark, and then every 3 months for at least the first year. And at these visits, it's mostly just taking, volume measurements to track progress, and then also, kind of keeping up to date with their compression, taking measurements for new compression. Um, Really, there's no deviation from this protocol. A lot of our patients, ask if they could go to two thigh highs, or if they can wear a night garment. And the answer is no for everything. When patients have deviated from the protocol, which we try not to do, but if it happens, the outcomes are just not as optimal as if they stay in the protocol. Um, so every time a patient is getting their garment measurements taken, we really pull on that tape measure tight. And then we're also actually comparing to the measurements that were taken preoperatively on that opposite limb and making sure that they're at least that circumference. So let's say on a calf, like I got a measurement of 30, but the pre-op measurement was 25, I'll take 25. And that way we're kind of allowing the limb to kind of get even smaller and smaller at every garment change. That sometimes even the patients can be at like a negative, so their affected limb is actually smaller than their unaffected limb. Um, and sometimes with that, we can pull in the tape measure. Sometimes patients feel like they need more, we can increase the compression class. Replace more often, which obviously can be difficult with insurance barriers. But those are some of the things that we do to kind of just really tighten everything up and to keep working on getting that limb smaller and smaller at every garment change. Um, and that's it. Kind of brief. But anyway, I think it's really important to, have a lot of for patients to have a local therapist because especially at all those 3 month increments, it's of course if they can't come here, it's good to have someone locally and kind of understand the process and help us in any way we can, because we have a lot of patients that come from far away. So it's really nice to have someone close by that they can rely on if they need anything. So thank you all for helping with that.
Thanks, Katrina. That was great. I know you felt like it was brief, but I mean, I know what you guys go through, but to hear it like in that detail, it really is so much effort to make sure the garments are the right fit.
Yeah.
Um, any questions? You can either raise your hand, you can put it in the Q&A. If you raise your hand, I could take you off mute, I think, if I could figure that out. I'll ask just a general question, Katrina, because we talk about it a lot during our conference. What patient characteristics make you worried about them not going to their inability to tolerate this level of compression afterwards? And how do you gauge? And you mentioned it a little bit, but what do you do preoperative to make sure that they're going to be on board with doing this postoperatively?
Yeah. So, a lot. So it kind of depends on like what their management routine is preoperatively. A lot of our patients, if they've never tried a custom flat knit garment, I will always have them try that pre-op because it is just so different than a circular knit compression sleeve or stocking. So I'll always have them try that first. I don't always have the patients try like the full waist high, especially if they don't really need it up there. But yeah, and a lot of the times I also want patients to make sure they can wear it 24/7. So a lot of patients have night garments. So I'll actually have them try to wear their day flat knit garment at nighttime to make sure they can tolerate that okay. And if a patient can't, then I wouldn't move them forward because, this is what they have to do afterwards. If some people have like if it bothers them in certain places or there's pain, then they're not going to be able to tolerate that afterwards because like I said earlier, there's a lot of pain associated initially for this surgery that if they can't tolerate before, then they won't be able to tolerate it afterwards. So that's kind of the biggest thing I'm looking for. And then of course also just making sure that they're kind of maximized and in good, really good control of their edema. But that's kind of the biggest thing. And if they either can't or are unwilling to do that, then I wouldn't push them forward.
Yeah, it can be tricky. I'll say it's one of the biggest things when we initially meet patients. They're disappointed to hear that that is what is required after surgery, but I think most patients we've seen postoperatively are happy with it. Obviously, we have the bias of the patients that ultimately, bought into it.
Yeah,
But it is
absolutely.
demonstrates how what great things we can do, but also the limitations of what we can currently do.
Hmm.
And it takes a team. So thanks again for everybody for joining. Any questions, always feel free to email me, either questions about the webinar or questions about patient care. And then certainly any questions or recommendations of next webinar topics. We're always looking for new ideas. I think our next one tentatively will be about managing infections and cellulitis in patients with lymphedema, because often the therapists are the first line for these patients and want to help identify and guide patients on that approach. So thanks again. Enjoy the summer. We'll connect back again in the fall. Thanks, Katrina.